Dear student, in this video we are going to discuss about infertility and IVF or in vitro fertilization. Learning objectives are definition of infertility, factors essential for conception, common causes of infertility both male and female, investigations, treatment and the assisted reproductive techniques or ART. Definition of infertility. Infertility is defined as a failure to conceive within 1 or more years of regular unprotected coitus. Factors essential for conception. From our previous knowledge of fertilization and male and female reproductive tract, we know what are the factors essential for the conception. So this is the female reproductive tract. After the copulation, there will be millions of sperms will enter into the female genital tract, and the sperms will move in this direction. Okay, and from the ovary there will be release of ovum, and it will be taken up by the fimbria. So ovum will move in this direction. So there will be fertilization at the ampulla of the uterus, and after that the fertilized ovum, it will come and it will be implanted on the wall of the uterus, and there will be generation of embryo or blastocyst. So the factors responsible for conception, it is a healthy spermatozoa deposition, ability of the spermatozoa to undergo capacitation, acrosomal reactions and adequate motility, ascent of motile spermatozoa through the cervix, uterine cavity and the fallopian tube, ovulation, patency of fallopian tube, proper fertilization, receptive endometrium for implantation. So all these factors are essential for conception. If any of these factors are defective, then there may be chances of infertility. Starting from the spermatozoa deposition up to the implantation, in this whole process, any defect in any one of these steps may result in infertility. Now, causes of infertility. Male is directly responsible in about 30 to 40% cases, female in about 40 to 55% cases. Both are responsible in 10% cases, rest 10% is unexplained. Now, common causes of male infertility. So some causes are pretesticular. That is we know about the hypothalamo-pituitary gonadal axis of male. It will start from the hypothalamus, then it will go to the pituitary. In the pituitary, the LH will be released, that will stimulate the testicular cells to secrete other hormones. So this pathway. So any disruption of this pathway are the pretesticular cause. Now any defect in the testis itself, they are the testicular causes. Beyond testis, we have the vas deferens, we have the seminal vesicle, we have a long pathway through which the sperm will come out. So any defect in this pathway will be known as the post-testicular causes. In addition to that, there may be sperm-related factors responsible for male infertility. So what are the pretesticular causes? It may be the endocrine causes like gonadotropin deficiency, thyroid dysfunction, hyperprolactinemia. It may be psychosexual causes, erectile dysfunction, impotence, drug-related and genetic problems. All these are the pretesticular. Now within the testis, there may be immobile cilia, cryptorchidism, undescended testis, infection of the testis, drug-induced changes, immunological causes, Sartori cell only syndrome, where the Sartori cells are present, the germ cells are absent, so spermatogenesis will be absent, primary testicular failures. These are the causes related to the testis. Post-testicular causes, it may be obstruction of the efferent duct, it may be congenital or absence of vas deferens, Young syndrome. There may be tuberculosis or the gonorrhea in the post-testicular ductular system that may be responsible. Surgical vasectomy. Others, there may be ejaculatory failure, retrograde ejaculation, bladder neck surgery. These are the post-testicular causes. Now, what are the common causes of female infertility? Female causes. Number one is the ovary. So there may be anovulation, corpus luteum insufficiency. These are the causes related to the ovary. Then when the ovulation is okay, but if there is any problem in this fallopian tube, that is, there may be tubal infection, there may be pelvic endometriosis. So the patency of the tube is not okay. So tubal cause is around 25 to 35%. Ovarian cause is around 30 to 40%. Then there may be uterine factors. Uterine causes around 10% due to unfavorable endometrium, chronic endometritis, fibroid, congenital malformations. All these are responsible for uterine factor of infertility. Now then there may be the cervical factor, 5%. Then ineffective sperm penetration. There may be chronic cervicitis, immunological factors, that is presence of anti-sperm antibody. These are the cervix related causes. Now in addition to that, there may be pelvic causes like endometriosis adhesions, which may also contribute to the female infertility. Now investigations of infertility. So suppose a couple is complaining of infertility, then what are the investigations? But before going to investigations, we must know what are the objectives of that. Objective of investigation is to detect the etiological factors, obviously, to rectify the abnormality in an attempt to improve the fertility. If any defect is identified by this investigation, that can be repaired in order to improve the fertility. And most importantly, to give assurance with explanation to the couple if no abnormality is detected. Now when to investigate? As per definition, the infertile couple should be investigated after 1 year of regular unprotected intercourse with adequate frequency. But the interval, however, it may be shortened. Instead of 1 year, it may be shortened to 6 months if the woman's age is 35 years or more and the man's age is 40 years or more. Now what to investigate? So we know the objective of investigation: to find out the etiology, to repair the defects, to assure if there is no defect. We know when to investigate. If even after 1 year of unprotected intercourse at a regular interval there is no pregnancy, then there is requirement of investigation. Now what to investigate? Both the male and the female factors are to be searched for. So usually the semen analysis is done first to rule out the male factor, followed by the confirmation of ovulation to rule out the ovary related causes, then the confirmation of tubal patency. It is important that both the partner should come at the first visit. Detailed general and reproductive history should be taken in presence of both, and clinical examination is carried out separately. Now these are the flowchart of evaluation of infertile couple: history, physical examination, semen analysis, determination of ovarian factors, that is, these are the factors we see whether the ovulation is satisfactory or not, then endocrine investigations, and in order to see any pathology of the uterus or tube, hysterosalpingogram or HSG can be done. Now investigations for male partner. So semen analysis according to WHO 2010, these are the parameters of semen. The semen is analyzed in terms of semen volumes, and this is the lower reference limit. It has been a change from 1999 to 2010. Semen volume, the lowest range is acceptable range is 1.5 ml. Total sperm count, that is 39 million. This is the lowest range. Sperm concentration 15 million per ml. Total motility, it is a progressive motility and non-progressive motility. 40% is the lowest range. Progressive motility should be, the lowest range is 32%. Sperm morphology, normal form, at least the lowest range is 4%. And the vitality, that is live spermatozoa, at least it should be 58%. So this is the lowest range of a semen analysis. Now, if in the semen analysis we find these factors, in that case we have to go for in-depth evaluation for male. If we get aspermia, hypospermia, oligospermia or oligozoospermia, azoospermia, low volume ejaculate, and problems of sexual potency. So what are the meaning of these terms? Oligospermia is a few spermatozoa in semen. Hypospermia is a small semen volume. Aspermia is complete lack of semen. Azoospermia is absence of sperm cell in the semen. And there may be teratospermia, abnormal morphology sperm, or maybe asthenospermia, that is reduced sperm motility. So oligospermia is related to semen, hypospermia is related to semen, aspermia is related to semen, whereas azoospermia is related to the number of sperm cells. What are those in-depth things that we will do? So serum FSH, LH, testosterone, prolactin, LH. Then fructose content in the seminal vesicle fluid. Then the testicular biopsy, transrectal ultrasonography, karyotype analysis, immunological testing. This can be done. Now investigations for female partner. So suppose in a infertile couple, husband semen analysis, it is normal. Then what are the next things we have to do? We have to look for ovarian cause, endometrial cause, cervical cause, tubal cause, and some hormonal cause. So for cervical mucosal study, we will do to see any cervical problem is there or not. In order to see the tubal patency, hysterosalpingogram or HSG will be done. Serum progesterone measurement we will do at day 21 of the cycle. We know that in the luteal phase the progesterone level is high, so we will see the progesterone level change whether it is present or not. Now come to other important investigations, that is the ovulation has happened or not. We can test it by basal body temperature test. So we will note down the basal body temperature. We know that post-ovulatory phase, due to high progesterone, there will be increase in the basal body temperature because progesterone is thermogenic in nature. So, and the basal body temperature will give a very specific biphasic activity. But if the basal body temperature is monophasic, then we can go for the endometrial biopsy at day 21 and 23. We know that at day 21 and 23, that means the endometrium or uterus will be in the secretory state. So because if there is no secretory stage and we have found that the basal body temperature is monophasic, then we can conclude that there is an ovulation. But if it is in the secretory phase, then we look for whether in phase the secretory changes, they are corresponding with the normal secretory changes, or it is out of phase. Then if it is out of phase, then we will suspect that the luteal insufficiency or LPD. Now if there is, so these are the investigations for the ovulation factors. The endometrial biopsy at day 21 and 23, we will find the secretory endometrium. So this is the picture of secretory endometrium. We know that there will be very tortuous glands present over here. There will be tortuosity of the spiral vessels, and secretory things will be there. So these are the secretory changes in the endometrium. And then we will look for the cervical mucus. So we know that if it is done during day 12-14, there will be Spin-Burkitt test will be positive. Fawn pattern, we will observe the sperm pattern, and the cervical secretion is cleary and watery. So this is a fawn pattern, and this is a Spin-Burkitt. The threadability or the stretchability is very much increased in cervical mucus. But just after ovulation, there will be loss of this fawn pattern, and this threadability is also lost. The secretion will become thick and viscid. So it will give an indication whether the ovulation has happened or not. Then we can measure the serum progesterone level. Serum progesterone level at day 8, it is less than 1 nanogram per ml. So after ovulation from the corpus luteum at day 21, its level is more than 6 nanogram per ml. We can also measure serum LH, urinary LH, and we can do the serial transvaginal sonography, TVS. So then transvaginal sonography will give us idea from day 12 to 14 whether the follicles are maturing or not. So whether there is, if it is done in 12 to 14 days, then the dominant follicle with a diameter of 20 millimeter will be visible in normal cases if the ovulation is going to happen. So these are the investigations we can do. Laparoscopy we also can do in order to detect the ovarian defect. Now we want to concentrate, we want to say few more words about the basal body temperature. Basal body temperature, there is a biphasic pattern. We can see that this is the phase before ovulation, pre-ovulatory follicular phase, and this is the luteal phase, post-ovulatory. So we can see the definite change of pattern. So this is known as a biphasic pattern of the basal body temperature. Now if pregnancy occurs, then this rise of temperature, it sustains along with absence of period. This is the duration of mens or period. Okay. And in an ovulatory cycle, if there is any problem in the ovulation, you will find that there is no rise of temperature throughout the cycle. Now what is the principle of this test? So the rise of temperature, it is secondary to rise of progesterone output following ovulation. Importance is that it helps to determine the ovulation. So it gives an idea or the timing of endometrial biopsy, cervical mucus study, or vaginal cytology. Because we know by endometrial biopsy we want to see the secretory changes of the endometrium. If we have an idea of the time of ovulation, then we can say that during this period is a secretory phase. So this helps us to have an idea about the cycle. Now also helps to determine the most fertile period of the cycle. So you can see that this is the most fertile period of the cycle. So this will also help to determine about the ovulation. Now regarding the basal body temperature procedure, the patient is instructed to take oral temperature daily on waking up in the morning before rising out of the bed. Now the body temperature maintaining throughout the first half, we can say it is maintained throughout the first half. It is raised 0.5 to 1 degree Fahrenheit following ovulation. This rise sustains throughout the second phase. This rise it sustains throughout the second half of the cycle and falls about 2 days prior to the next period. So that's why it is known as biphasic pattern. So there may be a drop. One important point is this: there may be a drop. This part, there may be a drop in temperature to about 0.5 degree Fahrenheit before the rise, and it almost coincides with either the LH surge or ovulation. The demonstrable rise actually occurs about 2 days after LH peak and with the peripheral level of progesterone greater than 5 nanograms. So this peak, it is 2 days after LH peak and with a peripheral level of progesterone greater than 5 nanogram per ml. Now regarding the other cause, we can detect the tubal patency by the laparoscopic dye test by hysterosalpingogram. So we will push the dye through the fallopian tube, and spillage of dye will give us an idea of the tubal patency. Okay, now regarding the cervical cause, postcoital test, where the presence of progressive motile sperm will be observed, and sperm cervical mucus contact test, where the sperm antibodies are detected. Both of these tests are done between day 12 to day 14. Now in vitro fertilization and embryo transfer. First, a bit history of in vitro fertilization. In the February 15, 1969, the journal Nature published a paper authored by R.G. Edwards. This paper told about the early stages of fertilization in vitro of human oocytes matured in vitro. Now in 1977, in the year of 1977, they successfully performed one in vitro fertilization pregnancy in human, and the first test tube baby was Louis Brown. And so these are the two eminent scientists, and for his work Dr. Edward was awarded Nobel Prize in the year of 2010. But along with them, there is a role of an unsung hero of India, Professor Dr. Subhash Mukhopadhyay. He is a brilliant scientist who pioneered IVF research in India, and in 1978 the first test tube baby Durga was born in Kolkata. Now indications of IVF. Why the infertile couple, when they will go for in vitro fertilization. If after investigation, if anyone finds there is tubal disease, endometriosis, male factor infertility, unexplained infertility, failed ovulation induction, and Mullerian agenesis. Patient selection: age less than 35 years, presence of ovarian reserve, that is at day 3 the serum FSH level it is less than 10 international unit per liter, normal uterine cavity, and HIV and hepatitis non-reactive. Now what are the steps? Step number 1 is we have to down regulate the premature LH surge. We have to down regulate the pituitary by using GnRH agonist. Why we are going to down regulate the pituitary? To prevent the premature LH surge. We want to have a controlled LH surge and ovulation and everything. That's why at first there will be down regulation of the pituitary. Step 2, controlled ovarian stimulation. So when the pituitary down regulation is achieved, we will give exogenous gonadotropin, because this exogenous gonadotropin will help in the maturation of the follicle. Now step 3, we will monitor the maturation of the follicular growth. Okay, so from day 8 we will do tests to see the follicular growth, and when we will see that 2 or more follicles are 17 to 18 millimeter diameter, along with the serum E2 level is more than 250 picogram per ml per follicle, then the step number 3, we will give HCG intramuscularly. Why HCG? Because this HCG induces the oocyte maturation. So first we have down-regulated the pituitary. Then we have given the controlled ovarian stimulation by exogenous gonadotropin so that there may be follicular growth, and when the follicles are matured, their growth are followed, and we will give the HCG that will help in the maturation of. Step number 4 is the oocyte retrieval. Oocyte is retrieved aseptically 36 hours after HCG is given. And step number 5 is fertilization in vitro. Approximately 50,000 to 1 lakh capacitated sperm are placed into the culture media containing the oocyte within 4 to 6 hours of retrieval. Step 6. Transfer of gametes or embryo. The fertilized ova at the 6 to 8 blastomere stage are placed into the uterine cavity close to the fundus about 3 days after fertilization. Not more than 3 embryo are transferred per cycle to minimize multiple pregnancy. Step 7. Luteal support with progesterone, because we know that the early pregnancy is maintained by the action of progesterone. So step 7 is luteal support with progesterone. Prognostic factors. Some factors may cause a failure of IVF. Most importantly is a maternal age. Ovarian reserve, if it is less, with increased maternal age, ovarian reserve will be reduced. Fibroid uterus, smoking of the mother, which may affect the prognosis of in vitro fertilization and embryo transfer. Thank you.